So good morning, everyone. My name is Eunice Atsali, and I work for Kenyatta University. At the same time, I'm the National Secretary for Midwives Association of Kenya. And how I'm going to approach this topic is, one, I'll speak a bit about anemia management and the challenges we are having, and also PPH and EMOTIVE bundle, just in summary, and also now talk about the gender consideration in implementation of EMOTIVE and anemia management. So we will begin by, just a second. Yes, we'll begin by describing what anemia is and using partly resources from Dr. Eli Odongo, and of course myself, and a lot of search from the internet as well. So what is anemia? When you look at the picture, the normal red blood cells, when you look at the film, when you're examining, looks like the one on the left. I don't know whether my pointer will work. Yeah, like this, the one I'm pointing at. And anemia seems to have lesser red blood cells within the film. So to define anemia in pregnancy is quite difficult. Why? Because of physiologic plasma expansion in pregnancy, which makes a woman get physiological anemia. And then, of course, ethnic variations of HB value. Sometimes you find some individuals who have very high HB because of where they belong, geographic location, and others having lesser HB value. So those are things to consider when defining HB. However, the CDC defines anemia in pregnancy as HB less than 11 milligrams per deciliter in the first and third trimester, HB less than 10.5 grams per deciliter in second trimester. And WHO defines anemia in pregnancy as HB less than 11 grams per deciliter without necessarily putting it in trimesters. And so the general anemia, especially in postpartum females, is defined as HB less than 10 grams per deciliter. So as a healthcare professional, you become concerned the moment a woman has an HB of less than 10 grams per deciliter. So severe anemia is linked to 7-fold increased risk of death or life-threatening bleeding after childbirth. So that means PPH. So a reduction in hemoglobin to 10 grams per liter just before birth increased the risk of PPH by 23%. So, and something of important to note is anemia prevention has been overlooked by WHO in its effort to cut death from PPH. So we need urgent changes in policy and practice. So while it's one of the leading causes of severe effects of PPH, there seems to be lesser effect or lesser focus on anemia prevention. And that is why we are now beginning to shout about anemia prevention in pregnancy. So the prevalence of iron deficiency anemia has been noted to be very high, especially in population of women who are pregnant. From the table, you can see that women who are pregnant are the most affected by iron deficiency anemia, and especially in developing countries where it's about 52.0%, while children are affected, but the severe effect of anemia mostly affects pregnant women. So when we are focusing on prevention of anemia from this table, we need to begin actually from childhood, because this will eventually, a child who's been affected by anemia, especially in developing countries, there is a high likelihood they will move with the anemia up to pregnancy and even as they become senior. So it's important to focus on prevention of anemia from childhood. and also in pregnancy mostly. So what are the consequences of anemia? Firstly, maternal mortality with high blood loss is the first consequence we are concerned about. And of course, maternal cardiovascular strain, reduction in physical and mental performance. And I can tell you, when you have an HB, even one lesser than your usual, this can actually affect your physical and mental performance. Reduced peripartal blood reserves. So when you have anemia, there is a high likelihood you will actually portray more symptoms of anemia postpartum. Then increased risk for peripartal blood transfusion. So women who become pregnant when they are already anemic, there is a high likelihood they will end up getting blood transfusion because of the effect of anemia. Insufficient milk syndrome in postpartum anemia is also another effect. And fetal risks linked to anemia and iron deficiency include intrauterine growth retardation, prematurity, death in utero, infection, and fetal programming. So there can be an issue with fetal placental issues, especially when it comes to getting enough iron for the fetus. So how do we diagnose anemia in pregnancy? Previously, I think maybe someone can just type, and then Maulid or Dr. Eli can tell me, how do you do it in your practice? When do you do HB check? Maybe 10 seconds. In your facilities. How frequent do you do HB check for women?
Yeah, this has been a challenge in many facilities. We would really love to hear how frequently we are doing HB testing.
Yeah.
Not that I'm... Linda Kilonzo has answered first visit mostly. This from which facility, Linda? She didn't say which facility.
Okay. So I think what Linda is saying...
Machakos, yeah.
Okay. What Linda is saying is quite true, that most of the HBs are done at booking. But then it was noted that HB depreciates as the pregnancy progresses. And therefore, it's important that HB is checked at every trimester. So the current guidelines are indicating that you need to do screening of anemia at booking, then in the between 24 and 28 weeks, and at 36 weeks. So that is actually the recommended, so that at least we prevent the issues of women coming at birth with anemia, and yet we record the HB that was done at booking, that is maybe in the first trimester or the second trimester. Yet these women, sometimes because we fail to do physical examination, we end up with PPH because the effect, the anemia has developed over time within different trimesters. So the other way is we need to be able to do lab assessment. Iron deficiency anemia is characterized by microcytosis and hypochromia. So, and also there's, when you do lab investigation, you'll find low MCV and elevated red blood cell distribution width. So with this, you have to begin treatment. But however, in Kenya, we almost give all the women the iron therapy. And then, of course, history and clinical assessment. So women who are anemic will possibly talk about fatigue, alopecia, pica, restless leg syndrome, stomatitis, glossitis, and in severe cases, you may find them portraying signs of congestive cardiac failure. So that's in very severe cases. So there are two types of iron deficiency. That is absolute iron deficiency. That is where we have body stores for iron are really depleted. And then functional iron deficiency, where there's inadequate iron supply to meet the demand. So this is very important when we are checking the HB for women or when you are doing an assessment. So what are the interventions that have been put in place to tackle anemia? So firstly, testing and treatment of anemia using digital methods and point of care treatment with special focus on pregnant women and school-going adolescents. And because remember, it spoke about trying to tackle this from childhood. So if we are able to tackle from school-going adolescents, then there's a high possibility by the time they become pregnant, the childhood anemia may have been taken care of. Then addressing the nutritional causes of anemia in endemic pockets with special focus on malaria and hemoglobinopathies and fluorosis. So for example, in some of the areas like Western regions and coastal regions, it's important to put this woman on antimalarials. Then management of severe anemia in pregnant women is undertaken by administration of IV iron sucrose or blood transfusion. And there is a trial that is taking place, which we are hoping is going to have a breakthrough within the country to see whether iron transfusion, especially for severe anemia in pregnancy, will be able to prevent severe effects of anemia in women. So what are the interventions for tackling anemia still? What we do here is we give IFAS. Now the focus is thinking about how palatable is this IFAS for women. So we need to start thinking around it, because as we are giving, most women do not take because of the bad taste of the IFAS that we give. Then intensified year-round behavior change communication campaigns, and the campaigns are supposed to focus on improving compliance to iron folic supplementation and deworming. And this also goes hand in hand with campaigning for better treatments for more palatable iron folic acid supplementation and also the deworming medications. So, and also enhancing appropriate infant and young child feeding practices. This is just to ensure that you are preventing anemia from very early ages. Then encouraging increase in iron intake, rich food through diet diversity, quantity, frequency, or fortified foods with focus on harnessing locally available resources. And this is where our gender issues will come in, which we'll discuss in the slides that are coming. Then ensuring delayed cord clamping after delivery by 3 minutes in health facilities. So most of the time, it actually can pass even 3 minutes, but we target around 2 to 3 minutes so that you do the cord clamping. Sometimes as healthcare professionals, we are in a hurry, but the research has shown that when you delay cord clamping, you are ensuring that this baby has more reserves for iron, which may not be broken down immediately. So these are children that eventually will be better when in terms of HB as they grow up. So the other issue I think that I forgot to write in the previous slide is about data. So the data that we have, sometimes we don't capture the number of anemic cases that we have and also the severe anemias that we have. So maybe we can capture number of anemia, but the severity of the anemia is not usually captured. And therefore, that's how we go to our next slide, this slide that is talking about how do we tackle anemia. So firstly, it's access to service. And who determines the access to service? So firstly, is early ANC before the 3rd trimester. And you need to begin access to service at least at any gestational age. You need to be able to have HB check whenever the woman comes to you. Then the services that we need to focus on in order to prevent anemia include you need to test, and we are now thinking about point of care testing. So while we go on the screening, especially for other disorders in pregnancy on point of care like ultrasound, we need also to focus on point of care testing for hemoglobin so that we capture all those women that are coming mostly at birth. The first time that you are reaching this woman is at birth, then you're able to test their HB so that at least you predict the care you're going to give this woman. And then access to testing. This is where now the policy and also the gender issues comes in terms of ensuring that all women can access the testing for hemoglobin. And I think this will be possible if we have the point of care testing. And then, of course, we need to talk. And in talking, we need to focus especially every time the woman comes to the clinic, we need to talk about nutritional counseling. And this nutritional counseling needs to be patient-oriented or client-oriented because this client is coming to you as an individual. And sometimes when we speak in a blanket language, especially in terms of the nutrition, we normally just guide people without necessarily understanding their cultural values. So it's very important that we do the counseling in terms of which is client-centered and also culturally sensitive to this particular woman. Then we need to have a nutritional checklist so that we see where does this woman fit. So you have a checklist, especially in most places that can actually fit in the culturally acceptable nutrition, and you are able to check with the woman so that you advise appropriately. Then treatment, we need to be able to treat, especially with iron, oral iron and IV iron as appropriate. So in order to prevent PPH, eventually, we have to be able to take care of this test, talk, and treat. So firstly, test, point of care, make sure that you've tested. You find this woman is anemic or borderline or headed there. Talk. You need to talk about the nutrition. You need to talk about what they have in their diet, what is their usual diet, and how to enhance that in order to prevent anemia. And then, of course, now treat. In case they are anemic, you treat. In case they are not anemic, you still prevent by giving oral IFAs and, of course, IV iron. So we are going now to speak about the postpartum hemorrhage. Just shortly, I'm not going to define what it is because I understand that most of us are healthcare professionals. So what we are going to handle mostly is about emotive bundle and how gender issues come in the emotive bundle. So, but in the introduction, you will see that pregnant women are dying from different diseases. And what are they dying from? So 28% are dying from pre-existing medical condition exacerbated by pregnancy. 3% are dying from blood clots, and 8% are abortion complications. 9% are dying from obstructed labor and other direct causes. 27% are dying from severe bleeding, and 14% are dying from pregnancy-induced hypertension, and 11% from infection. However, most of these conditions eventually turn out to cause postpartum hemorrhage. So 73% will eventually complicate into PPH. So PPH is the eventual effect of all these conditions. So what are the causes? And I think in a snapshot, all of us understand, I think I'm preaching to the already converted, that excessive postpartum bleeding may be due to alteration in one of the 4 Ts. and that is the tone, which is uterine atony, can actually cause excessive bleeding, tissue retained products of conception, trauma, genital lacerations, and of course, even it's instrumental births and cesarean sections, thrombin. So, for example, clotting disorders like DICs can actually cause PPH. Although it is important to note that majority of women develop PPH, who develop PPH, have no identifiable risk factor. You go in the hospital, you have a client who has a good HB, they've had good attendance to the clinic, but eventually they turn out and get PPH. So it's very important to note that any woman can actually get PPH at the end of your care. So the PPH principles for treatment of PPH include one, risk assessment. So one of the risks that you are checking is anemia. The other risk is, has this woman had PPH before? Other risks include maybe, you know, is it surgery we are going to do? So you need to identify risk assessment through history taking. Then you do prompt diagnosis. So that in case this woman is developing PPH, it's very important to do prompt diagnosis. And this is where the midwife comes in, because the midwife is normally the first person with the woman and also the doctor. So we have to be able to do prompt diagnosis. And how do we do this prompt diagnosis? By effective quantification of blood loss and also effective physical examination. So initial stabilization is also very important, where you call for help and you do the usual ABC, uterotonics, fluids or blood, and a tranexamic acid. Then subsequent management depends on the cause, severity of PPH and mode of delivery. So for example, if it's trauma, you do surgery, surgical repair. If it's thrombi, you do infusion with blood products like FFPs. If it's torn, then you may have to use uterotonic drugs such as oxytocin, heat stable carbetocin, or just a carbetocin. Then if it's tissue, then you have to eventually do manual or surgical removal. If you find a woman whom you've already done this management and they still having refractory PPH, then this is a woman whom you need to escalate, because they may eventually complicate severely. What are the uterotonics for prevention of PPH and treatment of PPH? So mostly we have the oxytocin receptors or agonists are oxytocin and carbetocin in this category. Then we have ergot alkaloids like methigine and egometrin, prostaglandins such as carboprost and misoprostol, and we can also have combinations of both oxytocics and ergots, such as oxytocin and egometrin, and oxytocin or misoprostol, oxymesol. Then we have also antifibrinolytics, like like tranexamic acid. So, what are the recent WHO recommendations in terms of PPH management? So, there has been very rapid development in terms of PPH management because of the implication of PPH. And you can see the guidelines have changed very rapidly from 2027, 2028, 2020, 2023. So this is very rapid, and because it's a very important condition that needs effective focus on. So the recent WHO recommendations are talking about tranexamic acid, that early use of intravenous tranexamic acid within 3 hours of birth, in addition to standard care, is recommended for women clinically diagnosed postpartum hemorrhage following vaginal birth or cesarean section. Someone is speaking? So the other thing is the use of heat-stable carbetazine is recommended for prevention of PPH for all births in contexts where its cost is comparable to other effective uterotonics. And that advanced distribution of misoprostol for self-administration. So like in settings where women give birth from the homes and it's prevalent, these women can actually be given misoprostol to be able to prevent PPH following birth, and especially where there are constraints of distance to healthcare facilities. And in terms of assessment of postpartum blood loss and use of PPH treatment bundles, for all women giving birth, routine objective measurement of postpartum blood loss is recommended to improve the detection and prompt treatment of postpartum hemorrhage. So methods to objectively quantify blood loss, such as calibrated DREPs for women having vaginal birth, can achieve a standardized and timely approach to the management of PPH, and comprising an objective assessment of blood loss and use of treatment bundles supported by implementation strategy is recommended for all women having vaginal birth. So while we are talking about assessment, you need to ensure that there is a bundle attached to this assessment. I've identified that this woman has PPH. So what am I going to do? So the care bundle for the first line treatment of PPH should include rapid institution of uterine massage, administration of oxytocic agent and tranexamic acid, intravenous fluid, examination of genital tract, and escalation of care where necessary. So in the measurement of blood loss after birth, for all women giving birth, routine objective measurement of postpartum blood loss is recommended to improve detection and prompt treatment of postpartum hemorrhage. And methods to objectively quantify blood loss, such as one, calibrated DREPs for women having vaginal birth, can achieve this. So in most settings where there was the EMOTIVE trial, they were able to do to use calibrated DREPs in order to prevent PPH. Most measurement of blood loss, of course, after birth, most of the evidence on postpartum blood loss measurement comes from the use of calibrated DREP. However, there are other effective methods that can actually measure blood loss. So while calibrated DREP has been found to be very effective, you could actually use other methods that we are going to look at. The only trouble comes in measurement, especially following cesarean section. But DREP is actually one of the recommended method. However, there are many studies going on, especially in terms of sustainable and climate-friendly DREPs in healthcare. The care bundle to first response to PPH, a standardized and timely approach to the management of postpartum hemorrhage comprising of objective assessment of blood loss and use of treatment bundles supported by an implementation strategy is recommended for all women having vaginal birth. So the care bundle for the first line treatment of PPH should include rapid institution of uterine massage, as I've already spoken about before, oxytocin, tranexamic acid, IV fluids, examination and escalation of care. The other response is clinical judgment is very important to guide the PPH treatment in decision making. So in a large trial, the treatment bundle was initiated when blood measured blood loss was 500 mils or greater, or when measured blood loss was 300 mils or greater with early warning signs of excessive blood loss. So in the context of this recommendation, the guideline emphasizes on the need for consistent use of interpretation of the term bundle as a clinical care bundle for treatment of PPH. This should not be misconstrued with the use of this term in other contexts. So the use of bundle means that you are not missing out anything within the care. And we are going to look at the EMOTIVE bundle specifically as we go ahead. So how do we implement the new WHO recommendations? Firstly, measurement of blood loss after birth. So the first one is DREPS, that is the most effective one. And I would like to understand maybe from the audience, how do you measure blood in your facility following childbirth? Just 10 seconds, you can type. Anyone typing? Dr. Ellie?
I'm not seeing anyone typing. I really wanted to hear from the facilities how they are measuring. I know Voi have calibrated drapes as part of the EMOTIVE having been a site. That's true, Manajuma. I don't know about Steve. Steve, no one has typed yet.
Okay.
From the reports, Dr. Kello? Yeah,
Yes,
Dr. Evelyn.
morning.
Good
Yes,
morning.
Hi, good
morning.
morning, Dr. Keller. Yes.
Good morning. I work at the Kisumu County and Referral Hospital. We are in the process with our in charge, trying to see how we will get the drips. We have seen what we've been to Vihiga, and we have seen they were able to just get a local fundi to actually make something that is not so expensive. So we are in talks with my maternity in charge to just see how we can also have that, because we have not been accurately measuring blood loss especially for vaginal deliveries.
Okay.
It's been a challenge in my center.
Yeah. And I think, oh, good morning.
Yeah, from Lodwa, we equally are in the process of trying to procure the calibrated drapes with the procurement department. So far, we do approximation and are just trying to see how much blood is lost, but not objectively measuring.
Yeah. Thank you so much. Yeah, because, and I agree with you that doing approximation, sometimes eyes can lie, eyes can really lie to you. And I had another slide that was indicating that, but I removed it because I was like, I think I'm preaching to the converted already. So, but when you think about looking with the eye, sometimes you don't necessarily do objective measurement. And so in some places, I think where trials have taken place within this country, they've used DREPS, which was found to be very effective. A woman looks very stable, but at the end of the day, you are able to assess and find that this woman has PPH from the objective measurement. So you eventually institute the bundle approach in the, prevention of the PPH and treatment of the PPH. So there are other measures. So DREP is one of them. And I like Kisumu, that you've already gone to benchmark with Vihiga who are using the local fundis. And I think that's one of the ways that we can ensure that we are doing objective measurement in a cost-effective way. But I understand that KEMSA is already importing some of the DREPs at a fairly affordable prices. So maybe we could also explore that. Then trays, maternal wells can also be used, although they are not very friendly to the client. And other local innovations can also be done, because while we are utilizing the DREPs, we could actually use local innovations. And then, of course, you need to also ensure that, is it sustainable and is it environmentally friendly? So that's one of the very important things that, as even if we are doing innovation, we need to think about environmental sustainability of the drapes that you're going to use or the materials you're going to use. But of importance is that we have to have a way to objectively measure blood loss, because this is going to also help us in collection of data. Then the care bundle, approach or fast response for PPH. So we have had several trials within this country, Ampli PPH pilot, which was done in Makueni. I think it's already done. Then EMOTIVE control sites, and also USAID funded Momentum Country and Global Leadership in piloting in supported counties. And I'm glad to talk about Midwives Association of Kenya. I think we are going to do a scale up of this within 5 counties in the country. So how do we implement the care bundle that I've been talking about, which is the EMOTIVE? So the E for the EMOTIVE bundle is for early detection and trigger criteria, which is aimed to detect, which is aids in detection of PPH as early as possible and ensures that no PPH was missed. So early detection, calibrated blood collection drips was used for collecting all blood, all PPH blood. Then training on blood loss monitoring chart, which was developed during the trials. Then blood pressure and pulse is supposed to be checked, documented at least once in first hour postpartum, which I know in most facilities this doesn't happen, but I think it's very important to do this because you're able to determine when there is PPH without necessarily seeing visible blood loss. Then health workers requested drips with yellow warning line sign, and I'll show you how it looks like. Red action line at 500 mils. So Nigeria, Kenya, Tanzania, blood loss reaching yellow line at 300 mils combined with abnormal observation or vital sign triggers a motive bundle. And in South Africa, 300 mils yellow line acted as warning to prepare to treat if bleeding continued. So this is in the trials that took place before. And this is the drip we are talking about, which is usually put under the woman's buttocks immediately after childbirth, so that you're able to measure blood loss effectively. So here, when it's calibrated, that means there are measurements. And when the blood loss reaches 300 mils, it gives you a warning. And especially if the woman, maybe you do a physical exam, you see there is increase in pulse rate, lowering blood pressure, then you can initiate the bundle approach. However, sometimes when you can wait until 500 mils and then you start acting with the motive bundle. So the key implementation points that were done when birth was imminent, upper portion of the drip was placed under the buttocks of the woman. Transparent funnel was folded up to ensure this is the transparent drip was folded up to ensure that no amniotic fluid entered the drip during the birth. Then cotton straps at the end of the drip were used to secure drip around the woman's waist. After birth, staff administered oxytocin for third stage management as per usual practice. And then the funnel was opened. So this area was opened and hung over the edge of the bed before the placenta was delivered. This allowed all blood to be collected within the drip. So now, in case blood loss was at 300, then you start being alert. So the drip was calibrated 300 mils, highlighted yellow, that was warning. And then, of course, 500 red triggered a motive bundle for PPH treatment. So all blood loss after birth was collected into the drip for at least 1 hour or up to 2 hours if bleeding continued. And same drip was used during transfer to postnatal ward if within 2 hours. So all blood-soaked pads and swabs were placed inside the drip in case of multiple births. The funnel was rolled out after the last baby was born and after oxytocin was administered for third stage. So I think that is one of the implementation points that we need to note, some of the implementation points that we need to note as we are using the drips, so that we avoid also overestimating of the blood loss. So this is summary of DREPs developed and those in pipeline. Excellent fiber DREPs is available. That's plastic and biodegradable, which is very recently developed. And this is what we are campaigning for in the country, so that at least it is able to help, of course, in biodegradability. Then AirGuard EnviroCare Limited, semi-reusable, being piloted and tested in Kenya. Then U of Birmingham, reusable DREP, prototype using Macintosh sheet. Then Kenya Malindi Innovative Hub, reusable using Macintosh in use in labor wards. Then in Nigeria, we have plastic clean DREPs, prototype new products, and also being tested. And also in South Africa, there is a proposed model of eco DREP. So India DREP from apron. So the plastic aprons were used to make the DREP. So in Kenya, we can innovate in any way so that we have ours that is customized and also eco-friendly. So what is this, the EMOTIVE bundle that we've been talking about? So once you've done detection of PPH, so firstly, you get into the M, which is massage of the uterus. Then you give an oxytocin drug, which can be either oxytocin or carbetocin. And then you can also do tranexamic acid immediately, which should be done within the first 3 hours of PPH. Then IV fluids have to be given immediately. And what we normally do, we give 500 mils rapidly. Then, of course, you now do 500 in the next 4 hours. Then, of course, you examine so that in case there is an issue with the genitalia, you stitch or you escalate care. And in case of refractory PPH, you also now rebegin. But of importance, as we talk about the EMOTIVE bundle, you don't have to follow the order. Like now, start with massage uterus. All these things can be done concurrently, so that at least you make sure that you've handled every aspect without necessarily following any order. But the most important thing within this is collaborative care, so that I've identified as a midwife at the bedside, then someone is calling, which is escalation of care. And as I've identified, I'm also massaging the uterus. So there's a lot of collaboration care that is required within the EMOTIVE bundle approach. And I think this table just explains the same. So on PPH prevention, the use of carbetocin, that is 100 micrograms, is recommended for prevention of PPH for all births in contexts where its cost is comparable to other effective uterotonics. And of importance to say is we already have it within the country, and it's also cost effective. I think it's about 95 shillings per one. And in places where it's been used, they say that the woman is dry. Like, for example, you've identified the woman has already lost about 300 mils. So you give the heat stable carbetocin or carbetocin. Yeah, on PPH diagnosis and treatment, early use of 1 gram intravenous tranexamic acid is considered to prevent severe effect of PPH, and that is done within the first 3 hours. Then objective measurement of postpartum blood loss in women experiencing vaginal birth, and a standardized and timely approach on PPH management consisting of objective quantification of blood loss and treatment care bundle, supported by an implementation strategy in women experiencing vaginal birth, is very, very important. So what are the gender considerations? And I think I've touched a few as I was going along, but then it's important that we speak about gender considerations when tackling anemia and EMOTIVE. So one of the things is you will realize that there is biological differences between our pregnant women and other people in the population. And the iron requirement and absorption in this population has to be specific. And also these women have to be considered when it comes to having more iron supplementation. So the other factor or gender consideration that we need to talk about is socioeconomic factors. So there are many barriers, especially when we are trying to prevent anemia in women. And financial barrier is one of them in low and middle income countries. And who actually determines all this in the household? For example, who determines that this woman is supposed to go to the clinic in the first place? Because most women depend on their either spouses or their parents-in-laws, so that they can be able to have the financial muscles to be able to go to the clinic. And we cannot tackle anemia and also PPH unless we talk about the families and the involvement of family within the healthcare ecosystem. Because sometimes we have very beautiful guidelines, but at the end of the day, who determines the transport this woman is going to use to the clinic? Who determines the cultural factors that are affecting this woman, especially who are having anemia? Who determines the nutrition this woman is going to have, especially during pregnancy? So these are the people that we need to bring on the table, especially in the decision-making table, so that as we are telling the woman, you need to be taking a balanced diet, the husband needs to be there so that they are able to, to understand why we need this balanced diet for the baby and for the woman, and why it's important for this woman to go to the hospital or to go to health facility or to seek professional care during pregnancy. Cultural and social practice is another factor. So there's influence on the dietary habits in some of the communities. So for example, I'll talk about my own community where I come from, where a woman was not supposed to eat eggs during pregnancy because the baby will be dumb or will delay in speaking. So how do you negotiate around this as a healthcare professional so that this culture people can understand that, yes, of course, culture is saying I cannot eat eggs, but can I eat omena instead? Or can I eat this other food or termites or mushrooms so that I'll get the same benefit from the food that I would have gotten? Whom do you bring on the table in terms of speaking about all this? So firstly, as healthcare professionals, we need to consider the family, so that when we are speaking to this woman, because this woman will listen to you, but deep within her, they are thinking, but I cannot change. I cannot change this. But you can change that by ensuring that you bring together the families and also the political ecosystem, and everyone that is involved in the care of this woman. The other thing that is very important when we are thinking about gender consideration in tackling anemia and emotive is healthcare practices. So gender considerations may influence how healthcare systems approach and prioritize anemia screening and treatment during pregnancy. And this particularly goes to who makes the decision, especially in terms of policies. Who are at that table? Whom should we include within that table that will be able to bring the effect of anemia? Because we are just looking at PPH, but then we are not looking at how does anemia impact on PPH. So it's very important that we have all the healthcare professionals together, and at the same time we have the service users, so that they are able to make, decisions together. Then, of course, we need to also ensure that we have targeted health education, which include decision makers in this education. So we need to make sure that we are including the decision makers. So for example, I have my husband. So if I'm talking about balanced diet, if I'm talking about prevention of anemia, my husband should be able to support me. If I'm talking about palatable iron treatment, then the person who is buying that medication needs to be in the conversation. Then policy support. Policies that support access to prenatal care, nutrition supplementation, and iron-rich foods can help mitigate anemia risk. But who is at this policy table? And that is the question I'm posing to all of us, that who will be at this policy table to ensure that we are talking the same language? How do we involve our MCAs within this conversation, because we may not progress without having the MCAs, without having even the CEO of the hospital within this conversation. We cannot progress without having even the other people that are decision makers, because our society is patternistic in nature. There is that hegemony and power issues. So how do we ensure that this power issue is actually being mitigated by ensuring that the conversation is all round? So the other issues is task sharing and the role of midwives, nurses, community health workers in managing PPH and anemia. So I like the bundle EMOTIVE, because in EMOTIVE, we are talking about collaboration of care. And in all this, we are ensuring that all the healthcare professionals feel they are being useful within the care of these women. And I think this is something that we need to be, to encourage and also talk, so that there is synergism within the care of women, and especially in prevention of anemia. Then patient-centered approach to include her voice in addressing causes of anemia and how diet and management can be most effective to her. We need to listen to the clients and midwives to address early warning signals for PPH and anemia. Because with the hegemony issues in healthcare system, I'm afraid to say that sometimes you identify PPH as a midwife, but the escalation, as you escalate, the response is a bit slow unless the woman is collapsing. But if the woman is hemodynamically somehow stable, the response is usually a bit so slow in healthcare practice. So we need to come together as healthcare professionals and be able to synergize, so that when we identify early warning signs, we should be able to be listened to as midwives, and also as healthcare professionals all around. We need to listen to one another. Then importance of good funding for obstetric emergencies in government and hospital budgets. So as we go to those policy tables, we need to make especially obstetric emergencies to be the center of conversation. But even before we get to the obstetric emergencies, for example, anemia has to be prevented early enough. So how do we put obstetrics at the center of the table? So it requires a big voice. And I think as societies and associations, we are here to give more voice to that. Then training of all cadres and education within communities. We need to ensure that we are training everyone equally, so that everyone can be able to handle especially anemia, and also can be able to handle PPH effectively. And I think that's my summary of gender in EMOTIVE. And thank you very much. In case of questions, kindly type or ask. Asante.
Yeah, thank you for the clear presentation, Dr. Atsali. You brought in a lot of science and left the icing on the cake for the last 3 slides. I was just waiting for the last 3 slides to see how we can integrate gender in all these matters. Very impressive. I've learned a lot, especially regarding how do we improve, especially address anemia. Those cultural practices that you've mentioned, the foodstuffs and all that. Yeah. So we have a lot of work to do in the gender matters. And I'm going to ask Professor Moses Obimbo to make a comment. We only have 4 more minutes, because Prof, you only have 2 minutes, then I have 1 slide to present. Prof.
Okay. Right. Thank you very much. Thank you, colleagues. Thank you, Dr. Eunice. That was brilliant presentation. I've listened. I always learn every day, and I'm so excited about what you're doing and how impactful this kind of forum is useful in terms of helping our patients, helping our practice. And so we'll be taking advantage of your slides and your encouragement to answer some of your questions, because the questions you posed, how many reflect on this, do this, the important questions to really take our thinking, our research, our paradigms to a new level. So I'm very, very excited about this. I just wanted to also make a point to inform all the members here. Eunice and I and a few other people are working on the postpartum hemorrhage project. And one of the pillars is advocacy and community engagement. So this is spearheaded by the University of Nairobi and in collaboration with the Kenya Obstetrical and Gynecological Society and also the Midwife Association of Kenya. And we just planned for the first world ever postpartum hemorrhage run that will be on the 6th of October 2024, starting at the Ulinzi Sports Ground Complex. The officiation will be by the Minister of Health, who I've been in touch with, and she's confirmed her attendance. She will come, and we've received quite a lot of backing from UNICEF, WHO, USAID, US Embassy, and many other stakeholders. Our colleagues at the Midwife Association of Kenya have been really at the forefront of this. You know, I can see the poster ready out and the link to registration. So I want to take this opportunity to invite all of us for this very worthy cause to raise voice and spotlight the issue of postpartum hemorrhage so that those who do not know can actually get to know about it and invest more resources in managing postpartum hemorrhage. And of course, just make it a daily kind of routine that people driving from Karen, for example, get annoyed when they see the roads are blocked and they learn something or two about PPH. The intention is to make this an annual event, and we want to scale this up not only in this country, but the entire Sub-Saharan Africa, South America, Southeast Asia, and other places that would benefit from this kind of advocacy strategy. So you're all welcome, and we'll be happy to see you stifling the dust and showing people how best you can, you know, have a jig and a jog at the same time. Thank you very much and have a great day. Thanks. My 2 minutes are up. Thanks, Ellie.
Thank you, Prof. About stifling the dust, you've spoken with alacrity. Thank you. It's always a pleasure listening to you, Prof. There's a question about Rosalba had a question as Maulida puts up my slide. I only have 1 or 2 slides. Rosalba, you have a question? Can we unmute Rosalba? Is Rosalba still there? Maulida, are you able to unmute her? Or him? I don't know. I don't know the gender, Eunice.
I'm on.
Oh, yeah, please. Please ask your question.
Okay, thank you very much. This has been very an eye-opener for management of PPH. I work at Lodwar County Referral Hospital, and we find that in Lodwar County Referral Hospital, we have a challenge of blood product, especially mothers who present with PPH and the cause is DIC or low platelets. There's this factor that is used, factor 9, that is used in children or people with hemophilia. I just wanted to ask, in case we don't have the blood product, can we use the factor 9 to administer to these patients? And how effective is it in prevention or in reduction of the PPH? That's the question I wanted to ask. Thank you.
Thank you. Maybe I'll prefer that to Prof. Obimbo. I don't know whether factor 9 works in PPH. What I'm surprised is that you don't have blood product, but you have factor 9, Rosalba?
Yeah, okay. The thing is that we don't have blood every other time. Sometimes patients present at the time when we don't have blood at the blood bank in our hospital. So
thank you.
To save the life of that mother, do you think that we could use factor 9 in order to stop the bleeding? I don't know. That's what I wanted.
Or maybe the mechanism of bleeding are different. Well, I'm not a guru in PPH. I'm an oncologist. So maybe Professor Obima, the mechanisms of PPH are different. I don't know whether factor 9 would be included in the armamentarium, in their arsenals, Prof. Obimbo.
Yes, I think there are quite a number of algorithms for use during management of PPH, from uterotonics to those methods of non-surgical or surgical interventions, and then the use of antifibrinolytic agents and procoagulants. So factor 9, I think, falls in those recombinant procoagulant issues, which in my opinion, I think as you surprised earlier, I'm also surprised that there'll be no blood product, but then there'll be recombinant factor to promote coagulation. It's not one of the mainstream things, so I'm not going to put my neck on the rail for it. But if it's available, and there's, of course, enough evidence to show recombinant factor 7, factor 9, factor 10 can be used to manage PPH, so go for it. But I think, in my opinion, we need to get the basics ticked first before we go to those more expensive, and sometimes we do not know the real side effects. Though this morning I've just been challenged that we have to challenge our thought dogma. We always think the things we've known in the past are the right ones until someone tells you something new, but we always try to resist. So Eli and I will probably take advantage of this to learn more and see how much more investment we can make in learning of this factor 9 and the other recombinant agents.
Yeah, thank you.
Thank you very much, Rosalba, for pricking our curiosity in this matter. So I'm just going to take one more minute. We've been collecting data, and thank you very much, the facilities that have been submitting data. And this is from our analysis, slide number 2. Maulida, you can... yeah, so this graph displays effective coverage for EMOTIVE from each facility. Of course, these slides were shared with you, and we realized that we have a reduction in effective coverage for the last quarter. And the reasons are given there. Like Kisumu County, the measuring jar was used once, but no measuring equipment available at all times. And I think Dr. Evelyn has already mentioned this, how they are going to really look at what Vihiga is doing. And then in Lodwar, bundles delivered in full, but there was no measuring equipment available. In Nkubu, TXA missed a few times. And in Moi County Referral Hospital, we have 6 months supply of calibrated drapes. So the last slide, which will be available to you, is that what might be contributing to the changes is what we need to ask ourselves. Which activities are having an impact on the data? Are there external factors, like what Lord has already mentioned? Maybe no blood, but you have other recombinant factors. And we need to consider how this project can improve effective coverage. Of course, in the interest of time, these slides will be shared with facility coordinators and also can be interrogated in the facility. This is the data that we've received so far. With those very many remarks, I would like to bring this to an end. And thank you very much for attending. And thank you, Atsali, for preparing, and Obimbo for enlightening us and the questions that came to break our curiosity. Thank you. And God bless you all. Have a good day.
Thank you so much. Good day.
Good day.
Good day.
Good day.